Welcome to the Heart of Innovation. 60 minutes that could save life and limb with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by patient advocacy group thewaytomyheart.org in partnership with Cardiovascular System Incorporated's patient advocacy campaign, Take a Stand Against Amputation. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of The Way to My Heart, Kym McNicholas, and interventional cardiologist and founder of the Save My Piggies Health Education Series, Dr. John Phillips.
Hi, everyone, and welcome to the show. A lot of our episodes really revolve around a debilitating disorder called peripheral artery disease, which is a circulation issue caused by plaque buildup, mainly in the leg arteries. And the reason that we talk a lot about this particular disorder is because it is becoming more and more prevalent. Whether or not a doctor diagnoses it is a whole other story and part of the problem, which is why you may not know about it, but it does impact 1 in 5 people over the age of 60. And you would know if you are experiencing the leg cramps, some numbness in your legs, leg pain, that can really indicate that you might have peripheral artery disease and you should get checked. But one of the best forms of medicine is simply walking. So later on in the show, we're going to talk all about the right way to walk, why walking is important, and whether or not other exercise formats can actually help you with P.A.D. And we have some researchers that are going to be joining us. But first, hey, John, it is so good to see you. I love seeing you every week.
Oh, Kym, you're so sweet. Happy Saturday. Hope you're doing well. Evidently, you're in London.
Yes. I mean, how could it not go well? I'm at the Find Your Rhythm Algorithm conference by Dr. Lorenzo Petrone. And it's just one of quite a number of conferences where they talk about peripheral artery disease and advanced tools and techniques for unclogging those arteries that lead to the feet. So lots of great discussions here. So
yeah, it should be. Yeah, I imagine there's a lot of discussion about what to do from an interventional standpoint. But I think today, if I got the notes correct, we're going to be talking about non-interventional ways or non-invasive ways to potentially treat this chronic disorder. Part of, as we've mentioned in multiple shows, we discuss a walking program and really kind of put a lot of emphasis on patients who have peripheral arterial disease walking as much as they can to kind of help build what we call collaterals or bypass vessels to allow for improved blood flow and less pain. But this is kind of a chronic, debilitating issue for some people. In fact, this morning I got a consult from a gentleman who he's trying to work. He has blockages in multiple areas, and a lot of the kind of like the litmus test for our patient's ability to ambulate, it centers a lot of times around going to the grocery store or whatnot. And in this small town that I get referrals from, they only have a Walmart. And so I'll hear like, okay, they can walk half the Walmart or a third of the Walmart or the whole Walmart. And that is my kind of like guide for, all right, well, maybe we can manage them conservatively, or do we need to be a little bit more aggressive? But on the heels of this kind of being a chronic illness, hopefully my inspirational quote or several sentences of quote will be a benefit for our listeners.
Oh, fantastic. So it's time.
Dr. John Phillips' spectacular vascular moment of inspiration.
Indeed it is. So I was kind of looking through some quotes about chronic pain because I think as we progress in the show, we're going to discuss some alternative ways to potentially help people that have pain from P.A.D. But I found this quote, and it's several sentences from a researcher at Stanford by the name of Sean Mackey, who's an MD, Ph.D. He gives a lecture called Pain and the Brain. And in part of the lecture, he's quoted in saying, and again, there's several sentences, so forgive me. But he says, getting up each morning, we can reflect on how we can't be certain if the day will unfold as we think it will, and then resolve to greet it nonetheless with curiosity and wisdom. Greeting the day with curiosity means being interested in what each moment has to offer, and greeting it with wisdom means not turning away in aversion from our experience, even if it's unpleasant and even if it's not what we had hoped for, which I always think is interesting because you wake up and you have plans for the day, and then the plans get derailed because life happens. And a lot of times folks that have peripheral arterial disease or any other chronic illness, it's hard to get out of bed sometimes. But I think the fact that you can just get out of bed, lace up the bootstraps and get out there and do something is a victory in my book. And hopefully today we will learn from our colleagues across the pond about alternative ways of potentially treating peripheral arterial disease.
Right. I mean, as you know, most people with peripheral artery disease absolutely never need a procedure at all. They really do need to walk. Walking really is the best medicine to improve the circulation and relieve a lot of the symptoms of leg pain, neuropathy, as well as the leg cramps. But I really like your quote, because we have an after show to the Heart of Innovation, which you have to go to thewaytomyheart.org/one step away to get details on how to log into that particular after show. But a lot of times during that after show, which is hosted by one of our P.A.D. warriors, as we call him, Douglas Salisbury, and also legendary Harlem Globetrotter, Larry Shorty Coleman, who has had one leg amputated, and we've saved the other. But one of the mantras for him and for Douglas is, you just got to take one more step. You have to wake up in the morning and you have to say, you know what? Thank you for giving me life today. Thank you for allowing me to take a step. And I'm going to take one step. And then that's going to lead to another. So it's just one step at a time.
Truly is, as they say, a journey of 1,000 miles begins with a single step.
It does. Like and let's take the next step and let's introduce our researchers from Scotland who are joining us really, really late in their evening. We have Kym Seenan and we have Daniel Tiboldi, and I'll let them each tell us about what you do and what your research is. We're going to start with Kym.
Great. Hello. Hello, everybody. Thank you very much for having me this evening, or this evening for us over here. My name is Kym Seenan. I'm a senior lecturer, or what you might well call a professor, in physiotherapy, and physiotherapy, what you may call physical therapy. And so I'm based at Glasgow Caledonian University in Glasgow in Scotland. And as you mentioned, my research interest is within peripheral arterial disease, and specifically focused around interventions that look at addressing the pain experienced during walking, and encouraging increased physical activity and that behaviour change around physical activity. So that's me. Thank you for having me today.
Thank you, Kym. And Daniel.
Hello, so my name is Daniel Tiboldi. I'm also joining from Scotland, as you heard. I'm a doctorate student in physiotherapy here at Glasgow Caledonian University. Much of my research revolves around intermittent claudication and its self-management strategies that I've looked at over the course of my research. I'm not as experienced as Kym Seenan in research yet, but this will be my first systematic review that I'm going to publish eventually, yes.
Fantastic. And we can't wait to hear all about it. So coming up right here on the Heart of Innovation, stay with us. We have more with Kym and Daniel from Scotland, and we're going to be talking about exercise and how to improve your circulation. So stay with us.
Leg health can indicate risk for heart attack, stroke, and amputation. If you have leg pain or cramps while walking, get checked for peripheral artery disease, or P.A.D. P.A.D. is plaque buildup in mainly the leg arteries. Be sure to ask your physician for an ankle brachial index, also called an ABI test, where they use blood pressure cuffs to analyze the blood pressure in your legs. If they discover you have arterial plaque that's limiting blood flow to your feet, medicine and a regimented walking program are frontline treatment. If P.A.D. is in its advanced stages, your physician may schedule a surgical intervention. Minimally invasive tools are available to remove plaque and restore blood flow, including Cardiovascular System's Diamondback 360 atherectomy system, which sands away plaque that is a hard calcium. It's important to discuss all options with your physician, and if told you have no options, get a second opinion. Take a stand against amputation. For more information, go to standagainsamputation.com. That's standagainsamputation.com.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thanks for joining us. We are super stoked to have two researchers in, I guess, what we would consider physical therapy here in the U.S. From Scotland, discussing kind of alternative methods for treating intermittent claudication, or kind of that discomfort that patients get with peripheral arterial disease when they ambulate after a certain distance. And before we went to the break, we had just got to meet Chris and Daniel, and I think we'll just, kind of continue as we were. So, Chris, tell us a little bit about how you got into looking at peripheral arterial disease as a physical therapist, right? And then ultimately doing some research in TENS, or kind of that that transcutaneous stimulation.
Yeah, absolutely, no problem. So my interest in peripheral arterial disease really stemmed from the pain aspect, as I mentioned. So it was in my practice, and when I was practicing as a physiotherapist, pain was one of these things that I was just really interested by, in lots of different conditions, about kind of how we experience it and what it does to an individual, and how it prevents some people from doing things that they want to do. So
Are you dealing with a lot of people who had P.A.D.? I know P.A.D. is pretty prevalent, but it's very rare when I have a physical therapist here in the U.S. say, oh yeah, I deal with these P.A.D. patients all the time. Were you dealing with a lot of these patients?
Yes, I was. And I think it might well be due to the kind of the slight difference between a physical therapist in the US and a physiotherapist in the UK. So in the UK, a physiotherapist, we kind of, perhaps, well, my understanding is that we do slightly more of the vascular, cardiovascular, and respiratory aspects. So I was working on respiratory wards and vascular wards, and so therefore I was seeing people before surgery, post surgery, and that was where I got my first experience of seeing people with claudication with peripheral arterial disease.
Fantastic.
And so how do you end up putting two and two together with the TENS device and P.A.D. and thinking that might help a person? Because one of the issues patients have is, as they're walking, they start to get, because of that restricted blood flow that is starving the muscles, the tissues, they start feeling the cramping in their legs and their feet and such. And you decided to put a TENS device on these patients to see if it would help improve their walking distance by relieving that cramping feeling.
That's exactly right. And it was interesting. It was from my undergraduate degree, so when I first studied physiotherapy, and we were doing a project where we would get students, unsuspecting volunteers, into the lab, and we tie a blood pressure cuff around their thigh and pump that blood pressure cuff up so it basically reduces the blood supply to the lower limb, and then get them to do exercise to induce this pain. So the reason we were doing that kind of level of what you may consider torture to
I guess you don't have very many friends anymore.
no, not many people liked me after I did that to them. But it was to study the pain experience. So we're really interested in, and also this was this is called an experimental model of pain. And so it was a way that you can test interventions on pain. So I was doing this with individuals, and we were testing TENS, and TENS works to reduce this pain in these healthy individuals. And then I think, well, wait a minute, this is the same thing as is happening in my clinical population, where there's a lack of blood supply to the leg. Perhaps TENS might work for these people too. And that was
Chris, sorry to interrupt. Could you just tell the audience what TENS, what the acronym stands for, and what exactly it does, what it's been proven to do in folks with chronic pain, so we get a little bit better understanding of why it might help with these folks that have P.A.D.
Yeah, of course, no problem. So TENS stands for Transcutaneous Electrical Nerve Stimulation. And what it describes, and it kind of does exactly as it says on the tin, really. So transcutaneous means across the skin, and then electrical nerve stimulation just indicates it's electrical current that's stimulating the nerves. So what happens is with a TENS device, it's a small kind of about this would fit in your pocket kind of size device, and then it's attached to the body through electrodes which stick onto the skin, and then current is passed between these two electrodes. What it does, and the way that it works, is that the electrical current which passes over the skin is perceived by the body and by the brain as a tingling sensation. So you get this kind of feeling of tingling or kind of pins and needles type thing where you have the TENS on. And the theory and the way how it works is that tingling sensation overrides the pain sensation. So you put the device on the body. So if it was for when it's in P.A.D, it's over the leg. If it's on back pain, it's over the back. You put it wherever you're feeling that pain, and it uses a mechanism called the pain gate theory, which means the body focuses. It can only focus on one pain or one feeling at a time, and so your brain perceives the tingling rather than the painful stimulation.
Cool. And so you conducted this research. You decided that, hey, there's something to this. It's working on these, people who are no longer friends anymore. And so now I'm going to take all of my work and what I discovered, and I'm going to apply this to vascular patients. So you created this formal study, and what did you find out?
Well, what we found out was that TENS works. So in a very controlled environment, so it was on a treadmill with people with P.A.D. We asked people to walk on a treadmill to induce their pain. So it was on one of these treadmill tests where the gradient increases every 2 minutes. We did a test once with no TENS and once with a TENS machine. And the people walked further with a TENS machine. So that was what we found.
So Chris, did you find that this was an adaptive, response, or maybe were they able to walk longer the longer they had the TENS on, or was it kind of you wore the TENS and then you got another, 30 or 40 feet and that was kind of it, or could you build on it, I guess?
Well, we didn't actually test that in the study that we did, and that's what we're looking at now. So we're doing further studies now to see if you have the TENS, because they only had the TENS on that one time on the treadmill.
Oh, I see. So this was just kind of proof of concept.
Exactly. That was a level that was quite small numbers, and just basically to find out, does this work? And we have subsequently done another study where we gave people the TENS device home to use for 6 weeks, and we looked at how far they were walking at the start and how far they were walking at the end of that 6 weeks to see if it happened.
And then this is how you hooked up with Daniel?
Well, yeah. So Daniel is on our DPT program at a university, and he was very fortunate enough to be allocated to me as a supervisor. And so what Daniel's been looking at is a bit wider than TENS, because what we've identified is TENS is useful, but it's not the only thing. There needs to be more. It's a useful addition you can add to your walking. But what else helps you manage this condition and what for. And that's what Daniel's been looking into.
And it's not that the TENS device actually improves your condition. It's a catalyst, right, for getting you to walk further without as much pain that would stop you, so that your body will continue to have that response to grow collateral vessels, which we haven't really gotten into that part yet. So I want to hold that thought. Let's start the next segment there and talk about why walking is important, and then how this TENS device supports that whole process. So stay with us right here on The Heart of Innovation as we continue this very powerful conversation.
3 years ago, my symptoms started with leg pain and leg cramps while walking.
Me too, with a tightness in my calves.
Well, do you know, my doctor thought that my leg cramps were a side effect of the statin he prescribed me.
Well, my doctor just brushed them off as another symptom of old age.
Mine thought the pain was radiating from my spine.
My doctor blamed my neuropathy on diabetes until I got a wound on my foot that just wouldn't heal.
Yeah, it turns out we all have peripheral artery disease, also known as P.A.D.
It's plaque buildup mainly in the leg arteries causing poor circulation.
For me, the diagnosis came too late and I lost my leg, but that does not have to happen to you.
No, it does not, because there are treatment options available if you're diagnosed early enough.
P.A.D. Peripheral artery disease. If you've been experiencing leg pain, leg cramps, or neuropathy when walking, and your doctor isn't hearing you, we are. We are The Way to My Heart, the largest support network for peripheral artery disease patients, and we want to help you get back on your feet again. Visit our website at thewaytomyheart.org or call our Leg Saver hotline, 415-320-7138. Your life and limb could depend on it.
Welcome back to The Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. We're continuing our conversation about alternative ways to get people to walk a little bit in the setting of really significant peripheral arterial disease and the symptom of claudication. And Chris was just kind of explaining their proof of concept using the TENS device to, I guess, I don't know, is it tricking the brain a little bit to allow you to walk a little bit further? But when I counsel patients with respect to a structured exercise program, and here in the U.S., we have what's called cardiac rehab. So if someone's had a heart attack or bypass surgery or something, they can go to a facility, structured exercise program. It's covered by their insurance. And we also have that for peripheral arterial disease. Now, there are a lot of roadblocks in getting folks to enroll in that, one of which is cost sometimes. Another is just proximity, because a lot of our patients live in rural areas where they don't have the opportunity to actually go to some place to exercise. And so when I talk to them, I'm always reminding them, hey, just kind of get out and walk. And, easy for me to say that. I don't have the P.A.D, but oftentimes I am counseling them to walk until your leg starts to cramp or you're getting that aching heaviness, and then walk a little bit further, and then you have to rest and keep going. I have several patients who time how much they're able to walk, and they are able to show incremental increase in their walking distance, which I think creates a positive feedback loop for these folks. But you guys are taking it a step further to try to help develop these, what we call collaterals, or kind of these kind of quiescent vessels that aren't called upon unless there's a significant blockage, right?
Yeah, that's exactly right, and that's the theory and our idea of how TENS might work. And so it's just what we realized, and we've done a couple of systematic reviews and some other studies exploring, well, why do people not walk, when they have P.A.D, and what are the barriers, and what are the enablers? And it was exactly as you say. It was kind of that, the pain, the kind of the lack of motivation was one of these key barriers. And that was why we thought, well, if we can use TENS reduces, or at least makes the experience not quite as horrific as it normally is, maybe this would help. Maybe people would walk a little bit more. So TENS itself isn't the thing that's particularly fixing or helping the condition, but it's an enabler to kind of help do the walking.
You bring up a really good point in terms of the whole desire to walk. And I think part of the research that you've been doing, and I think I'd like to bring Daniel in at this point as well, is you're focusing on that education point, because, in some of the research that I've read from you both is you've had patients that have actually said, I just didn't understand why walking was important. You tell me walking is medicine and to go ahead and walk, and that somehow, some way my symptoms are going to improve. But I just don't believe you, because I feel this horrible pain and it feels like I'm going to hurt myself or I'm making things worse. But when you sit down and you explain the why and the how, is that what you found really helps the patients? Daniel, do you want to jump in?
Yes, absolutely. I think the education element of it, and just giving the patients the confidence and reassurance that the plan that they were given by the clinician actually is very helpful. And just knowing for sure that if pain arises through walking, it's okay to push through it. They're not going to hurt themselves anymore. I think having that reassurance is very beneficial, because a lot of the qualitative studies I looked at throughout my research, these studies stated that patients were scared that something more sinister will happen to them if they carry through with the pain. But that's just simply not true. And giving them the confidence and the reassurance, I think, is very important throughout the studies I looked at.
Can you pretend that, I'm a patient, or we even have, hey, Douglas, we have a patient that actually is calling in right now. Douglas, say hello. I want you to convince, Douglas has to walk every day. He has P.A.D, right, Douglas? You have P.A.D?
Yes.
And you struggle with walking?
Yes, I have.
How far did
it depending on the days, and sometimes it's 100 steps. Sometimes I can't go to the mailbox.
And so, Daniel, can you,
if I could this is going to be awesome. But if I could just say one thing, just to plant a little bit of a seed, because a lot of patients will tell me exactly what Douglas says. Some days I'm good, some days I'm bad. I get a lot of, walking on a treadmill is okay, but walking on concrete hurts. I get a lot of,
you too.
Any incline is really is bothersome, but I can walk on the grass. I mean, it's so variable, and I guess I don't necessarily understand why it's different for folks, and hopefully, you guys can help us. But sorry, I wanted to say that, because it's just so variable what patients can do on a day-to-day basis. And I think that ultimately affects their motivation sometimes too, to push through it.
I agree. And I'd like to get into that as well, but let's Daniel, do you want to jump in?
Yeah, sure. I mean, it's a good point that John raised about, having different days. Some days it hurts more, some days it doesn't. I would look at that as any regular workout, to be honest. Some days the body is just not feeling it, and you won't be able to do the same number of sets. Or some days it's going to hurt more. It's okay. It's sort of like just being aware of it, that, okay, well, this is what my body was capable of today, record it, and then hopefully work on it, increase the steps next time. And there's going to be a day when you'll be able to push through and achieve your target. But it's important to set smart goals. But also being aware that some days it won't go your way and you won't be able to achieve. But it's important to have like a structure. And that's something that I got from many research I read, where a structure in a walking plan is very important.
And so if you're talking to Douglas and Douglas is saying, hey, it's really a struggle for me to walk. Some days I walk, some days I don't. How would you educate him? How did you in that research program convince those patients to do it with the how and the why?
Because some days it's more the mental health than it is the physical for me, dealing with the pain.
And maybe go on, Daniel.
You can go, Chris, if you want. Yeah.
I was just going to say, if you're specifically referring to, we just completed this study of education. So we did a group education session to see if it would help people in this exact situation. And one of the things that we used, it was just as you described there, I think, John, and sharing that kind of experience. So if I use this type of shoe, I can walk a wee bit further. If I'm walking on grass, it goes further, and so on and so forth. And I think helping, and that group element of the education and a bit of those sharing of stories really helped, because it made people feel, all right, this is normal, this is okay, it isn't something different and wrong about me and something that's going on. The other analogy we used, and this specifically related about the pain, was the analogy of a crying baby. So your muscle is a bit like a crying baby in terms of, a baby cries when it needs something, okay, but when it cries, it doesn't mean it's hurt or it's in pain. It's just, it doesn't have any other way of communicating what it needs. And so it's a bit like your calf muscle, when it's sore, it's just trying to tell you something. It's not that it's hurt, it's not that it's in danger, it's not that it's harmed, but it's just, I need more oxygen. And why am I not getting enough oxygen, nutrients in the blood? So that was another thing I think people really hooked onto and said, well, that reassures me a lot. And now I can understand why it's okay to walk into that pain a bit further.
That's it. I'd never heard that analogy before. I had heard the one where one that's more towards, you're out there with your trainer and the trainer says, just give me one more rep, just give me one more rep. And you're like, oh no, I think I'm going to fall over. I can't give you one more rep. And you're like, just feel the burn, feel the pain. You got this. And then you just pull it up and that's one more rep. But it's for patients to understand, it's right then and there when your body is building those collateral vessels, correct?
Yeah, and that's what the research suggests, and it is walking into that pain. So as you mentioned earlier, if you stop just before you get to that pain, it's likely that you might not be getting quite the same level of benefit from that walking activity. So if you can push into it a wee bit further, and therefore for us, if TENS can help you push into it that wee bit further, then that's great.
And coming up right here on the Heart of Innovation, we're going to continue this conversation. We have a few callers that are calling in that we want to get to as well, so stay with us. We have more with Chris and Daniel from Scotland talking about exercise and improving your circulation, so stay with us.
Medical Notepad, brought to you by Cardiovascular Systems Incorporated's Patient Advocacy Campaign, Take a Stand Against Amputation, and The Way to My Heart.
Hi, this is Agustin, vascular surgeon from Spain. So I think today we can talk about revascularization infrapopliteal, when it's indicated, or what to do, and what sort of patients are best target for every specific treatment. And I think the first thing that you need to keep in mind that medical treatment is usually the best option. And when I think about medical treatment, I'm talking about anticoagulation like aspirin or clopidogrel, and also trying to keep your lipids lower. So talking about statins or whatever. So also the most important thing is just to keep on walking. Walking is the best medical treatment you can get, because by walking, you will increase your collaterals, and this will maintain your foot alive. Because the main issue is like when you need to treat a blockage. And the answer is a blockage is not the indication. You can have 100% blockage below the knee, but you may probably be free of symptoms. And I'm not talking about pain on your calf, pain on your claudication, you know that. Is not an indication for any infrapopliteal revascularization. For these sort of patients, the treatment is to keep on walking and to control your risk factors. Because we know that if you are a claudicat, you are not in risk of losing your leg. So when are you true risk of losing your leg? When you have pain on rest pain, or when you develop ulcers, toe ulcers or heel ulcers. So that's exactly the point where you will need a revascularization. And again, it has nothing to do with the degree of or the percentage of blockage you have on your arteries. So if you arrive to the state of you when you have breast pain or you have ulcers on the toes, on the knee, definitely we need to choose what is the best treatment for you, the best surgical treatment. And you can either choose endovascular or a bypass, and it will all depend on three important aspects. First one, what is your physical condition? If you are fit enough for a bypass, this is a good and durable option. The second one is if you have a good conduit, if you have a great first vein. I'm sure you all have heard about all of this BESIAL trial, which has proven that if you have a good vein, this is a good, durable option. But sometimes this is not the case, and you probably don't have a good vein or you are not fit enough. And for this, you need an endovascular treatment. But keep in mind that to get a good endovascular treatment, you need to have a good physician to perform your treatment. And this is not usually, or it's not always the case. I'm really concerned about all of these patients that ended up in a major amputation without even having a DSA to know if they have a vessel to be treated. So first step to keep in mind, just keep on walking. Second thing, once you get to this stage of having breast pain or any ulcer, just look for a physician that is going to look after you. Look for the good physician and never, ever accept an amputation before having an angio. And if you don't get an angio from your physician, look for a second opinion. I think probably this would be, generally speaking, a good approach for these sort of lesions.
Remember, the advice and views offered during this series are for informational and educational purposes only. Always ask your own healthcare provider for explicit consent before acting on any information provided here. If you want more information on peripheral artery disease, go to standagainsamputation.com. And for real-time support, go to thewaytomyheart.org.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. We're continuing our conversation about treating peripheral arterial disease, particularly walking and some alternative therapies as opposed to going right to procedures. One of the questions in the audience surrounds a medication called cilostazol or Pletol. That medication has been shown in clinical trials to improve walking distances in patients. And basically, it kind of helps prevent the platelets, which are the little parts of the red bloods or in the blood that kind of can cause some clotting. It kind of helps them from sticking together, but it also creates what we call vasodilation, and so dilates the vessels and allows folks to walk a little bit further. But yeah, I mean that's a medication that we use very regularly. There's a couple of patients who have certain heart problems, heart failure issues who can't use it, but a lot of patients, I would say half the people that I use it in do get some benefit and improve walking distance. The other half don't tolerate it. There's a lot of issues with GI upset and fast heart rates, but it's a good medication. And sometimes we actually use it to prevent narrowing within a stent that has been put in. There's some data to suggest that. Jumping back into our conversation though, and I think this is critical, and we were talking about this during the break, the whole notion, Chris and Daniel, of information sharing and developing a community around the peripheral arterial disease treatment options, particularly walking programs, or maybe we'll get to in a little bit other alternative means of exercise for those who can't walk. But share with us how you guys are developing all this information sharing. Is it more automated, like using mobile apps, or is it actually kind of getting people together and face to face and having conversation?
Well, the main way that we've done it to date is face-to-face and in conversation. So we have just completed a trial which we call the P.A.D trial, and the essence of that trial is we were looking at would group education, so getting a small group of people with P.A.D in a room and to talk about their condition and learn about their condition, would that help increase walking? And what we found is that the people who were involved in that study really enjoyed that element of getting in the room together, and the way that the education, it was quite structured education and based on the kind of current education used within diabetes. So there's a Desmond program that's used in diabetes, and so what the essence of that was that people would come to the room, they would share their story of diagnosis, share their story of their daily walking and their challenges they experienced, and talk to one another. And through that, find out that they are not alone, that that other people experience the same issues that they do. They gain tips from each other in terms of, oh, have you tried this? Have you tried that? What about this?
And was there any sort of preconceived, facilitation that you plan to ensure that it didn't become a misery loves company versus an inspirational motivational? There are two ways that it can go. How did you prevent the misery loves company versus the inspirational and motivational? Was it strategic? And had you thought about that ahead of time?
Yeah, that's a really good point. And I think the way we dealt with that is we had some very skilled and trained facilitators who, and the education session is very strictly kind of organized and it has a full curriculum that they do. So the program that we use is called the CEDRIC program, which was developed by other researchers, both from the US and from the UK, and by Professor Gary Chu who's now based in York in the UK. But they developed this program, and so that what we do is very much if it's getting to that point where people are, as you say, just spiraling down towards this kind of all these terrible things and experiences they've had, it's all about kind of parking those things and just giving space to air them, but then saying, okay, thank you for sharing, but we're going to focus on this aspect. And we used things like motivational interviewing techniques and other specific behaviour change theories and techniques within that session to help focus people on walking behaviour and setting goals and developing a plan for the future, basically.
How frequently do you think people need to have this face-to-face interaction? Is it weekly, monthly? Do you guys have any idea of what that looks like yet?
We don't really, because in this study, it was actually a one-off. So it was a 3-hour session, but we only met once with the group. Okay. And then the group would go home with a TENS machine, as we've talked about before, and the researchers would phone them every 2 weeks to check in and see, okay, how are things going? Because they set goals for their walking behaviour and they had a pedometer to see kind of try and increase their walking distance. And so that was what we've tested at the moment. But that was one of the things that the participants said to us at the end of the trial. We said, oh, we would have loved more of that. We think we should come back again. I want to keep in touch with those people I met during that session. And how could we? So that's where we're moving now. And that's a part of what Daniel's working on is, how can we facilitate that? And also how do we facilitate that on a wider scale so more people can benefit from that?
Yeah. What we're doing informally with the Way to My Heart, which, creates communities of these peripheral artery disease patients. We don't have anything formal, but it's been just this informal group. And what we find is the same thing that you guys found in your controlled study is if you have the right facilitation and moderation in there and you can get everyone focused on the same goal, it really becomes motivational. And people in our groups online on Facebook, as well as our app, there's a peripheral artery disease app people can download or on their desktop. And people are loving to share their steps every single day, their experiences, their wins, their losses, whatever it might be. But the fact that they're taking just one more step, everyone just cheers them on. And you have people that are taking 1 or 2 steps a day. And you have people that are doing 10,000 a day. We even have one that has gone from literally almost 0 to 25,000, hitting a huge milestone. And it's that community support.
Yeah, and I think it's kind of interesting, too, to look at it like, and I know it's apples to oranges here, but Alcoholics Anonymous, where folks are meeting, I think, pretty regularly, and they have a sponsor and really motivated group of people. But I think that leads to the success of abstinence and sobriety, because you're culpable, but you also have people that kind of got your back, so to speak, and you know who to call. obviously that's not an extreme example, but maybe P.A.D. patients don't need that. But P.A.D. is not, as we know, I mean, we don't cure P.A.D. It is a chronic illness, and it can be managed though. I mean, do you guys, would you envision ever creating something like that, or is that probably just a little bit too much, in depth?
I do think that's kind of almost what's required and what's needed. Or it might be, I think it might be that it won't be one size fits all. I think that what the solution might be, and that's what one of my other PhD students is working on at the moment, is they're doing a co-creation study. So they're sitting down with people with P.A.D, but also with healthcare professionals and their carers and other people to talk about, well, what would you like? What would work, and actually get the people with the condition to generate what, because it might be some people will say, oh no, I want to come to the gym once a week and exercise. Other people, that's the worst thing I could possibly do. I want to do it at home or in the community. And other people say, well, I really don't like exercising with anybody else at all. I want to do that bit by myself. But I would like to meet people and talk and to share stories. So that's what I think we're going to work towards. And that's probably where I see it, is that it's not going to be just a one thing that's going to work.
Daniel?
I just think that talking about sort of the frequency of the focus groups or sharing information with one another, I think the app that you have, Kym, is very useful. I think it's where medicine in general is heading towards, more holistic sort of approaches rather than biomedical. It's what my research was founding as well, is that it's very important to sort of look at the problem from many ways, psychologically speaking as well, and help them in all directions rather than just use medication to sort of help the pain. But I think sort of the more they can share their stories, especially not just with one another but with a clinician or an expert, I think that gives them the confidence that, okay, well, they're along the right sort of direction, and if they just push through, they can achieve the ultimate results that they want.
And coming up right here on the Heart of Innovation, we'll have more with researchers Chris and Daniel, so stay with us.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. We are coming up on the hour here, but we've got another question from Douglas regarding alternative means of exercise. Douglas.
So my question, on those days that I can't walk, what about stationary bicycles? What about swimming on a regular basis? The hand bicycles, what are other exercises that I can use to grow collaterals?
It's a good point, because a lot of our patients also have wounds on their toes and they can't get up and walk. They're told not to walk. So they need something else and know that they're making a difference. Chris?
Yeah, great question. And it's not something we've looked into specifically, but I do know there is quite a bit of work out there into this. Certainly from my understanding is any exercise is good exercise. And, and one of the key, and on top of kind of helping walk further, the key aspect of exercise is that cardiovascular prevention. That's stopping you progressing to having other major cardiovascular events. So anything that raises the heart rate, anything that kind of improves kind of the cardiovascular system, then that's exactly what we like. So yes, arm crank exercises, leg, stationary bike, rowing, cycling, swimming, as you mentioned, I think will work really well.
Because I can only imagine, I mean, you have the human superhighway, right? And if you are even moving your arms and you're raising that blood pressure, the blood goes through the body, right? All the way through. So, and it needs to pump through quickly to get back and continue to fuel it. So I would imagine it's doing something. It may not be as beneficial to the legs, right?
It is, but like they say in the gym, you can't skip leg day. So you gotta, and I tell my patients, if they can't walk, then a stationary bike, that the foot cranks that work too, I always say, hey, yeah, you can do water aerobics, but aerobic activity, but that's hard for a lot of folks. But I think there are ways to get the legs moving and build muscle mass and ultimately help improve walking distance or reduction in pain with claudication.
And Maria's asking about walking in water. Does that do the same as walking on land?
I mean, it makes sense, as John was saying there, if you can get those muscles within the legs working, then you're going to be asking the body to be pumping blood down through those vessels, then it should help. I think that's that aspect of, because a lot of the benefit of it, walking exercise, is that task-specific training. It's like you're practicing walking, so you're going to get better at walking and you will walk further. So, that would work too, I'm sure.
Fantastic. We have about a minute left. Any final thoughts, final takeaways that you want patients to have, from your research and from this show? We'll let you go first, Chris, and then we'll turn to Daniel.
Great. Thank you. Yeah, thank you so much for having me on. This has been a really interesting conversation. The main takeaway for me is that aspect of learning more about the condition and not being frightened of the condition and reducing the fear. So, speak to other people, reach out to other people with the condition and talk and share your stories.
Daniel?
For me, again, thank you so much for having me on this show. For me, the take-home message that I could recommend for patients is just having the belief that you can get better and you're not going to regress to the amputation stage, because you can do something about it. And we are all here to help you. And that's why we have those apps and websites, and just have like this holistic sort of viewpoint where you're free to share anything you want, and you can work on your mental and physical health, well-being as well.
Thank you. And
well
John, that's exactly the whole key with P.A.D, right, John, is really letting people know that it is something that you can do something about, especially if you catch it sooner.
It does not control you. It's just maybe a part of you.
Thanks, everyone, for listening to The Heart of Innovation. We hope you have a fantastic weekend and a great week ahead. We'll see you next Saturday.
You've been listening to The Heart of Innovation with Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips. Our mission is to help patients live a better quality of life through comprehensive education, real-time support, and high-touch advocacy in partnership with thewaytomyheart.org and Take a Stand Against Amputation. Our purpose is to reduce the 1.5 million heart attacks and strokes and nearly 200,000 amputations annually. For more information regarding topics you've heard discussed on today's program, go to theheartofinnovation.org. That's theheartofinnovation.org. The Heart of Innovation is for educational and informational purposes only, and advice and views shared are not a substitute for medical advice from your own supervising physician. Do not act on any information provided in this show without the explicit consent from your own healthcare team. If you think you are having a medical emergency, call your local emergency number or go to the nearest hospital or emergency room.